Dear colleagues, dear Drisi, thank you for your invitation. Thanks for the World Society for allowing me to present this topic, which will be in the mood of the session of today, controversies. It's a controversy will, I'm sure, provoke a lot of discussion. The practice of cardiac surgery in developing countries encounter a lot of difficulties. Lack of centers, insufficient qualified workforce, and very insufficient financial support. That's transforming ordinary activity in this field as performed in the developed countries in a daily challenge for local teams in developing countries. This situation becomes more complex when these teams have to deal with more difficult situations, like in patients with left ventricular dysfunction, especially in emergency. These situations with no possibility to have any kind of circulatory support lead to a very critical results in terms of mortality and morbidity. It seems logical to search the less aggressive approach towards the left ventricular function already altered. Ischemia reperfusion injury is well known as a consequence of cross-clumping on cardiopulmonary bypass. In this context, a beating heart surgery with no induced ischemia appears to be a reasonable option. Then why heart beating surgery? All these studies discuss the effect of cardiopulmonary bypass on beginning inflammatory syndrome, lesion syndrome, on the fibromyocyte, and on the left ventricular function itself. This goes to dysfunctioning the left ventricular function in the systolic and diastolic function. And it seems that this dysfunction is not only due to the edema provoked by the inflammatory syndrome, it is more due to the ischemia, due to cross-clamping. So if the ischemia is the major cause of dysfunction, why we can't avoid it simply? The next question is really a heart beating surgery efficient to reduce myocardial ischemia perfusion injury? Theoretically, yes, but in the real life, that is not another question. This study, which was a randomized study with two groups comparing for coronary surgery between on-pump and off-pump with no cross-clamping. And what's the conclusion of this study? There is no difference between cross-clamping and no cross-clamping on ischemia, on dysfunction. So is it true? Here we are another study. We say the opposite. In this population of patients, you have an effect of heart beating surgery reducing significantly the ischemia on the meiosis. We will return to this study after. And this other study proves that even it is not superior, it is not inferior to surgery with cross-clamping. So heart beating proved that it allows to preserve the left ventricular function in valvular surgery. On-pump heart beating give good outcomes and give good advantages. It is more physiologic than cardioplegia. The next question is this technique safe? That's the most question asked by a surgeon when we talk about heart beating surgery. Is it safe? Is there any risk of embolization? The first study proved that the heart beating surgery is as safe as conventional surgery. There is no major risk, supplementary risk in heart beating surgery. This one shows that on fibrillating heart, and we are seeing later the different ways to get this beating heart, is not inferior in terms of safety to conventional surgery. Better than this, it seems that it is better. There is less risk in heart beating surgery to cross-clumping surgery. And this technique, when it is used by experiment surgeon, reduce risks for dysfunction and not augment the risk for stroke. This technique allows to make different operation: replacement, repair, and we are seeing the different technique what we can use by this beating heart surgery. The first one, the classical controversy between on-pump and beating heart coronary surgery grafting. In this study, it's a meta-analysis from a team from China. They say that the beating heart surgery in this meta-analysis gave better results than classic surgery. But we said we have seen at the beginning of the slides that there are other publication saying the opposite. Here, I will ask you to see what is between the orange circle. It's a population of congenital. So VSD, ESD, pediatric population, beating heart surgery, given good results. So it isn't only in adult population you can use it. In coronary surgery you can use it. You can use it too in congenital heart surgery in pediatric population. And it gives the same results, not inferior to classic surgery. The same in mitral surgery, replacement, or even multiple valve surgery. On aortic position, mitral position, tricuspid position, bivalvular, trivalvular position. There is some different techniques to have a beating heart surgery, perfused heart in all these techniques, and it gave a good results. What about surgery for mitral regurgitation with left ventricular dysfunction? That's the question of the presentation. At the first point, what is mitral regurgitation with left ventricular dysfunction? Left ventricular dysfunction with mitral regurgitation began when we have a fraction ejection of left ventricle lower than 60. So it isn't the same definition of low EF in other pathologies. The MR is different. In the second one, the graph, the guidelines of the European Society of Cardiology of 2021, you see the possibility, the therapies, possible therapies for MR. You have surgery and you have interventional techniques for severe MR. I want you to remind this for the rest of the presentation. It is very important to get that in mind. When you have different possible therapies, different possible techniques, it isn't the same position when you are in situation you have no other possibility except one. And it will be more complicated when it is an ischemic. And even in countries with financial support, with experiment surgeons, ICU, in this kind of pathology, the results are not so good. And in this situation, the use of intra-aortic balloon is very helpful. It have good results. Now, does heart beating surgery in left ventricular dysfunction get better? No. The study say that it gives the same results than conventional surgery with very low EF, very low left ventricular ejection fraction, below than 10. It gives the same that the conventional surgery with cardioplegia. So what's the advantage? We don't forget that these studies are all in Europe and United States. So there are in centers with possibilities of circulatory assistance, more possibilities, even transplant heart, which not exist in our countries, a lot of our countries in the continent. The approach will be then different. We began doing beating heart surgery because we have patients with low fraction ejection. We have no other possibility to get this patient to the OR. When we used the classic strategy, we have a lot of mortality. So 7 years ago, we began this technique in Oran with my friend Dr. Shiban Salim here. And we began with a simple technique. medium sternotomy, cannulation, classic cannulation, aortic caval, snares on the chive, cardiopulmonary bypass on normothermia. When we want to open the left atrium, we put the patient in Trendelenburg position. We cross clamp the aorta temporarily. We open the left atrium. We put a vent into the mitral. We leave the clamp from the aorta, and we make our just technique on the mitral, repair or replacement. There is some rules we have to respect to get a clear field. The most important one is to ask to the perfusionist and to the anesthesiologist to maintain a high mean pressure. Why? Because when the assistant exposes the mitral valve, he will create an aortic insufficiency, and your field will be submerged. You can't see anything. So you have to make sure that your aorta is in tension. So even when your assistant retract, there is no possibility to make an aortic insufficiency. Don't let your perfusionist and anesthesiologist have a pressure below than 70. The ideal pressure is between 70 and 80, no more than 80, no less than 70. And then you are working in a very clear field without bleeding. You are working very, very easy. You have the same condition to a classic intervention. When you want to close your left atrium, you have to be sure that your vent is into the mitral valve or into the prosthesis, mitral prosthesis if it is a replacement. To make sure that there is no embolization after the closure. Your vent will be efficacious. And the rest of the intervention is like the classical intervention. The second approach is by right thoracotomy. It's a little bit different. The access is very good. You have a best view to the mitral by the right thoracotomy than by sternotomy. I prefer always to get, when I can, to get a right thoracotomy. You are in front of your valve, your mitral valve. You see very well. You make sure that your lesions are very well seen, and your technique will be perfect. The difficulties in the de-airing, it will little bit more difficult by the right thoracotomy than by sternotomy. And you have to be sure that your technique of de-airing is very well done. Otherwise, you will have problems with stroke or neurocognitive problems in the ICU. I will present you our little series in the Center of Cardiac Surgery, which is in the east of Algeria. I was there from 2017 to 2019. I will present you this series. It isn't a big series. It's 18 patients. It represents 1.6% of the total patient we have done in this period. 1,123 patients. We began in 2017 with 4 patients. We in the year after 7 patients, and in the last year before COVID, 7th patient. Predominantly, they are male. Age, mean of the age 54 years, with limits from 36, the younger, to 69. And surprisingly, we have the same rate of ischemic and rheumatic. We are a country with always a high prevalence of rheumatic in patients, surgical patients, but we are in epidemiological transition, and we have etiologic, different, the etiology of Africa and the Western world together. That's make the problem more difficult to.
Your time is running out.
Okay, I will make it. That's the background of the patients. Quarter of patients are class 4. 2/3 are sinus rhythm. The left ventricular EF, 43% mean, 27 the lower. 6 patients with right ventricular dysfunction with the left ventricular dysfunction, and 9 patients have coronography. 4 patients only have lesions on the coronography. The surgery, 1/4 was emergent. 1 patient have repair. 1 patient have a replacement with bioprosthesis, and all the other patients have a replacement by a mechanical valve. The associated procedures, 1 patient have a CABG, and the other tricuspid annuloplasty or replacement. This is the cardiopulmonary bypass times. We have 3 patients dead in the early hospital mortality. It's 60% mortality. It's huge. The 3 patients are died in emergent surgery. There are the 3 in class 4 of the 2 are ischemic, 1 are rheumatic. We have late mortality 1 patient. It's the only patient we made plasty repair 1 year after the repair. When you see the progression of the functional status, you see it is a good amelioration. All the patients go from 3-4 to 1-2 after 2 years of follow-up. For the EF, it's the same. All the patients have progressed evolution of the EF. It's slow, but it's always amelioration of the EF. There is no stroke or neurocognitive deficit in any patient. We summarize, we have heavy mortality in emergent surgery and especially acute ischemic mitral regurgitation. For the rest of the patients, clear progression in symptomatology at short and midterm, and slow progression of left ventricular systolic function at midterm. In conclusion, heart-beating surgery is an alternative in limited resources countries to give access to patients with critical situation, which in normal condition will need a circulatory support. This technique may be applicable for more common interventions in both adult and pediatric cardiac surgery. One thing to all our beloveds we have lose in this COVID pandemic. Thanks.
Thank you very much, Bouzid, for your presentation. The time has been used up. We may not be able to take questions and interactions.
Okay.
Except we have time at the end. We'll proceed.
All right, thank you very much, Abdelmalek. Nice presentation. We move straight to the next presentation, which is going to be given by Habib Gamra from Tunisia. He's going to talk to us about mitral valve balloon dilatation.